try to do it. So we will start the webinar, and I have to welcome everybody that connected to our meeting, but especially welcome our international guest, Professor Laila Harhaus, and she is working in Ludwigshafen. You know it already because I sent her very nice and long CV before for all the participants, just to know you more. We know each other from the hand diploma examination, and Laila was the best one last year. So this is really good, a big thing. It's not easy to do it, and really it's a big knowledge, and also a proof of a very wide spectrum of knowledge in hand surgery. But she is a plastic and reconstructive surgeon, and I think your favorite subject is nerves and microsurgery for sure. And because she's working in a big trauma center also, we talk with each other, and we propose the subject of management of complex injuries in upper extremity. So this will be covered by Professor today, and I'm happy you are with us. The floor is yours, and I will start maybe with some short questionnaire for the attendees, okay? So I will launch the poll now, and everybody that are attending the webinar, please just send your answers just to let us know you more. And the poll is just on the screen. We will give some minutes for people to answer. At this moment, we have 13 people on air. I think it will increase in time, but the vacation time is a vacation time probably also when doing our work.
And also we shifted the time a bit, right?
Yeah, but so it was my fault, so it's on me. I will have to recompensate this. You don't see the results, right?
No.
Yeah, no. I see the results. So
you see them already.
It's like a big wheel of fortune, you know. Now we are waiting for the real going down
surprise,
like this.
Right?
Yeah, no, it's I don't think it will be a big surprise, but it will give some kind of idea what the kind of people are now attending the webinar.
That was the intention to know.
Yeah, but I think even they will be experts. The webinar will be successful for sure, and your presentation too. So
I hope.
Okay, so I think I will just end. Maybe one person more. We will see. If not, I will end the poll not to lose our time. Okay, and you will see the results.
Yeah,
right
a lot
now.
of residents. That's wonderful.
Yeah,
very
I'm
good.
also
4
happy
to
about
6
it.
years, so experienced residents. Wonderful, welcome. That's great. Specialty ortho trauma, some plastic colleagues, wonderful, but a lot of ortho traumas. So I think we will meet all topics.
I told you that most of our society is orthopedic and traumatology specialists. So most of the people dealing with hand surgery in Poland are just derived from the specialty. So,
and most of you are from a polytrauma center, maximal care. So you probably see the cases we are talking about today. Wonderful, complex hand injuries, treating 1 to 5. Yeah, that's good. Above 20 even. Wow.
You know, but the way of treatment is the most important, and the organization of the healthcare in Poland is much different than in your country. So we will, I think, took a lot from this webinar, from the presentation, also asking maybe some kind of organization questions for you, how to improve the situation also in Poland. So I think we can start with the presentation if you are ready, and then we will get some questions for sure. We have also 2 cases prepared to kind of small discussion and to get your opinion, your expertise on it. And I will just say to everybody that if you have a kind of questions, there is a question and answers button in the bottom of the screen, and please ask like this, not by chat, by question and answers. Okay, so I think we can start with the presentation. Please go on, Professor.
Yes, thank you, Piotr, for this very kind words and introduction. And for all of you concerning our FESH experience, Piotr was my hardest examiner. So we had a hard time when we get to know each other.
Hard, but I think successful.
At the end, right. So now I try to share my screen with you. Where should I start? It's a bit slow. Now, is it okay now?
Yes.
Okay, great. So I have the great honor today to talk to you about a topic which combines us. So it's not only the German-Polish friendship, but also the ortho and plastic friendship and trauma friendship. And I hope we have a nice time together. So the topic today is management of complex injuries of the upper extremity. Let's start with a definition and to look onto this term complex injury. What does it mean exactly? For sure, we have an open fracture and we have an injury of all the other structures around the bones. We have arterial injuries, we have nerve injuries, the tendon injuries, and most of the time huge soft tissue defects. So we can talk of incomplete or even complete amputation injuries of the upper limb. And I have seen from the questions that you are very experienced, and for sure you have all seen this wide range of types of injury, which can be a very clear cutting injury, which we love because we can do a replantation very easily. We have very nice wound margins, and this is a nice situation for us to replant. But we also know the opposite. We have this huge damage. We have this crush injuries where all structures are meshed and destroyed, and there it's much harder to do a reconstruction and to keep some function. So what means management in this term? Management, as you know, comes from the Latin, means manus, hand, which we like, and agere, which means to lead. So we are the ones who taking over the leadership, the organization, and the planning of treatment of such injuries. And how do we do it? And we have a very clear strategy, which is shown here. We have first, for sure, an analysis of the defect. We have to know what's going on, what is defect, and what we have to repair. But for planning of the surgical strategy and the surgery itself, for sure, we have to consider the functional aspects we want to reconstruct. At the end, there is a big part of rehabilitation, for sure, but this is not the topic today. So let's try it. Let's go ahead. Let's try management of complex injuries of the upper extremity. Maybe with this case, we have a young girl, 17 years old, and she suffered a motorcycle injury, and with this a subtotal arm amputation, as you can see here. So when she is entering your shock room, your first department, what do you do? The first, what we said is you have to analyze the defect. For sure, you do the diagnostics, you do the X-ray and CT scans, and what you see here is she has an open complex humerus fracture with a huge defect zone. She has a mega soft tissue defect, and the problem is that the margins are not clear to assess. You see, especially in the distal part, that there are hematoma. You assume there will be necrosis in the next days. So this is not clearly to assess now. She also has a defect of the brachial artery and vein. So with this, she has an avascular situation of the arm. In addition, she has a median nerve defect, a radial nerve defect, and musculocutaneous nerve defect. She has a complete loss of biceps and brachialis muscles and a partial loss of the triceps muscle. So the worst situation you can imagine. And then for planning of our surgical strategy, we said we have to consider the functional aspects. And this does not only mean that we want to rescue the arm, we want the arm to survive for sure. And we do not only want the wound to be closed, for sure, this is a goal, but we want more. We want to restore function. That means elbow function, wrist function, finger function, out of this situation with lost muscles and nerves. Concerning the surgical strategy, in which order you have to do this reconstruction and you have to do these therapies, there is a clear consensus, and this is something you all know. There's nothing new for sure. First, you have to do the fracture stabilization. Second, you have to do the reconstruction of the perfusion, and then you can see, you can do the assessment of the damage of the nerves and muscles and do the decision making for the further steps. And this is what we did. We do such surgeries together with our trauma colleagues. So they did the fracture stabilization first with this plate. And what you can see is that they did kind of shortening of the humerus to get a good bone-to-bone contact within this defect zone. And also for us, it was a bit easier that all the destroyed structures could be shortened, and the reperfusion was a little bit easier. And this is what we did then as the next step. We reconstructed the perfusion with saphenous vein graft. This is nothing special. But when you look more detailed to this picture, you see something else. And this is pointed here with the arrow. We did in this emergency situation already ASM loop and vena from the greater saphenous vein, a loop to prepare the situation to do the flap coverage for the next day. So it was kind of damage control, but also considering the next steps already then. And we covered this situation. This was kind of middle of the night with a vacuum dressing. And then, for sure, this is now the time where we may discuss a bit or think a bit about microsurgical reconstruction and the best timing of flap surgery. We have this whole spectrum of emergency-free flap, which you do directly in the middle of the night, and the secondary reconstruction up to 3 months after the trauma, and everything between. And in such a situation, it's so hard to decide what to do. You have seen this huge defect, and you know you have to cover your structures and your arteries and your nerves, but it's in the middle of the night and maybe not the best time point for the patient. So when you look into the literature, for sure you have to cite Marco Godina, who is the pioneer who dealt with this topic and this question of the best time point and the timing of micro reconstruction. And he said it's the best time point when the patient is in a good general condition and not maybe in a shocking situation at the beginning of the trauma. You have to have a proper wound debridement, and when we have seen the situation from this patient, it was not a proper wound, and the margins were not yet clear, and also the surrounding has to be perfect. You have to create the most convenient conditions from the personal situation, for example, to do this microvascular transfer. And when he looked into his data, he stated that he had the lowest infection rate and the fastest bone healing in group 1. And this is to do the micro reconstruction within the first 3 days. This was his group 1 up to 72 hours. Is something you can suggest to be the best opportunity. And this is what we also did with this patient. So when you think again at this patient, yes, we had a stable patient, and we had complex defects with the extremity, with the arm at risk to fail. We had the exposed functional structures, especially the reconstructed arteries and veins. The reconstructive plan was developing at this time point, and the personal and structural resources, yes, we do have them also in the night, but we all are tired at 3 o'clock in the morning. That's no secret. When you have another situation, when you have an unstable patient, when you have a crush injury with absolutely unclear soft tissue situation, or if you have a situation with a limited resources, it's probably not the best time point to do the emergency free flip. So in this situation, it's always possible to cover the wound with such a vacuum dressing, but you all know that's only temporary solution, and our worst enemy is this granulation tissue, which really is a problem for all the gliding structures, for the tendon. So this is not a solution for a longer time. Yes, so what did we do? We covered this wound just for one night with a vacuum dressing, and the next day with surgeons, with fresh surgeons who slept well during the night, we did the soft tissue reconstruction with a free combined parascapular and the latissimus dorsi flap from the contralateral side. And what you see here is on the left side that we used this AV loop, which we created the night before, to do the anastomosis, to use it for the flap perfusion. And we already did a very huge flap. So all the tissue which was at risk, which was full of hematoma, and where we said, maybe it will be necrosis in the next days, we just debrided everything and covered it with a free flap and the fresh skin of the free flap. Why from contralateral? Because already then we thought about the next steps, and we knew the muscles from the biceps and the brachial muscles were gone. So we wanted to keep the ipsilateral LD muscle for the functional reconstruction of the elbow flexion, which we did later, 3 months later. These are the pictures from the next surgery. So 3 months later, we then, after salvage of the arm, we could do this flap. And what you see in the middle picture, the distal part is the very nice healed parascapular tissue from our first emergency surgery. And now, after some time, we can do the functional reconstruction. And this is the final outcome now 1 year after trauma. In this video, you see she has a good ulnar function kept. The median, even though we did sural nerve grafting, was not better, but she was fine with it. She did not want more surgeries. This is the function of the functional biceps reconstruction with LD. And this is a picture she sent us from her fitness department. So with that reconstruction coming from this very, very bad injury, she was even able to do this sports. So what can we learn from this case? What are the crucial aspects to be managed in cases of the complex injuries of the upper extremity? It is who is doing what and when. We talked a lot about the timing, but from this case, we also learned that such cases has to be treated in specialized centers with micro expertise. This center has to have the full armamentarium of all secondary reconstructive techniques like nerve transfers, tendon transfers, and also free flaps, free functional flaps. It has to be a trauma center for all the other diagnoses and all the other injuries for sure. And in the best situation, this center is the one who initiates the right diagnostics immediately and then plans the therapy in an optimal order and in concert with all the other departments who are necessary. And this aspect, I want to go a bit deeper again with another example. This is a case of 55-year-old male patient who suffered this paragliding propeller injury while he wanted to clean his paraglider, I don't know exactly. And he suffered this huge wound. This is his upper arm, his dorsal side of the upper arm. And he was treated in a small hospital with a small trauma department. And the colleagues there did everything right. This is a perfect example. They debrided the wound, cleaned the wound, and they looked for the radial nerve. They found that it was cut and there was a defect, and they just used what they had. They used this kind of easy flow drain and put the nerve inside that it was easy for us to find it in our second surgery. They covered the wound with a VEC dressing and then immediately referred the patient to our center. And so with this very good management of the colleagues, we were able already 6 days after trauma to do the proximal reconstruction, and this was a combined nerve reconstruction with a sural nerve graft. This is nothing special, and immediately the soft coverage with this ALT flap. And then, because we were very early, we immediately could schedule the next surgery already 3 weeks later for the distal nerve transfer. And you know, when you have a very proximal radial nerve injury, and even though you do a very nice reconstruction with grafts, you know the outcome, you know the long distance, and that the functional outcome is not very predictable. So our strategy is to go quite early to distal, do this nerve transfer, to have a safe motor-to-motor coaptation for re-innervation of the distal targets. So finger extension, thumb extension, wrist extension, and to re-innervate this within this this time frame of 18 months we do have for re-innervation. So after 1 year, he could send us this video. The left hand is the one which was injured, and you almost don't see the difference. It's a little bit slower, and I want him to finish. So he is a music professor, and it was very necessary for him to proceed with his job, and with this surgical strategy he was able to play again this Bach etudes which he could play before, so for sure he had to learn, because the finger extension was now done by the median nerve and not longer by the radial nerve. But this is something he performed very good, and he was very happy with this result. So coming to the end, we can conclude that complex injuries of the upper extremity should be treated in a specialized microcenter with all the other facilities on board. We know that the stable osteosynthesis is the basement of any following reconstruction. Sometimes emergency free flaps within the first 3 days are the best opportunity for functional defect covering. And we learned that the right timing of the right techniques by the right persons are the secret of success. So with this impression of our team and our hospital, I want to say thank you for your attention, and I'm happy to answer your questions now.
Thank you, Professor Harhaus, for this excellent presentation and a big introduction to this very complicated subject. I think most of our listeners are just, stunned with the presentation. They have even problems with asking some questions, but we prepared some very probably simple cases to discuss maybe with you more about the management and your decisions. How do you make decisions? How do you plan treatment? And I will ask Dr. Artur Soczka to put the presentation on with these two cases, just to give all of us more impression about how the management should be and what kind of solutions can be done in some specific situations.
Hello, good afternoon, everyone. So I start the presentation.
Dr. Soczka is a resident in our department. And I will have to say that he's also an anesthesiologist, very experienced anesthesiologist, that he just fell in love in orthopedic and surgery, and he started his residency some years ago. And now he is just about to finish and become an orthopedic surgeon. So he will have a very nice two specialties. So he would like to anesthetize and operate at the same time.
That is true. And I have to say now that I start my orthopedics residency in Germany. So I see you have a beautiful, big one, really large team of doctors. So I have a question to you, but after my presentation. But I can open the presentation, Peter.
Yeah, maybe I think Laila, you should close yours.
I did already, but I cannot leave them sharing the screen because they say
you have to go on. Okay. I will do something like this, and now we just kill your sharing at this moment, and now I will put the possibility back again, and I think now Artur is possible to do it.
Wonderful.
Okay. So we start with this presentation. This is really nice case, not short one. Okay, it was 40 years old man with injured non-dominant hand, no significant any other systemic illness. It was garbage truck worker, and it was the accident at work, admitted immediately in the orthopedic department. It looks like this, completely laceration of the dorsal part of the hand. And another picture. And yes, what is the best way to treat this injury? This is our question. And maybe after that, I show our effects. So maybe, Professor, what do you propose to do?
And because we have a professor now with us, we don't ask very easy questions. I mean, we don't tell too much about the case. This is not so complicated case. I put the case just for the discussion about some things because we had the problems with this case at the moment after our treatment. But please, Laila, what would you do in this situation? What would you like to know more, or maybe what kind of examinations you do usually, or what you suggest to do? Because we have also think and remember that we are looking sometimes from the different perspective. Most of us are orthopedic surgeons dealing with hand surgery and hand injuries, but not having mostly all of the capabilities that you told us before. So with the microsurgical solutions and the free flaps and so it is very nice to know what is possible to do in the best option. And sometimes we have to deal with this in another way.
Yeah, so is it right that the palmar side is okay? It's not.
It's okay. So it was okay, and there was a fractures of the metacarpals. I think I remember, and
the fractures, and then So my suggestion for sure would be to get the coverage, the soft tissue coverage. And if you say there is no opportunity to do a free flap, also very old techniques like groin flap would be a possibility. To cover just the situation, because also it looks like that the fingertips are okay. So
yes, yeah, and the vascularity
situation,
was also, so it was not so complex
can be
injury
closed
it could be.
nicely by a groin flap. And then the interesting question is the reconstruction of the tendons. It seems there are some rest structures left.
Yeah.
So if you go back, for example, to the free flap and the ALT, you can, for example, include kind of the fascia lata and create some new tendons from there. And the crucial point is that with that, you start immediately with the physiotherapy and with the movement. From the first day after the flap covering, which is for sure easier with a groin flap. This has to be maybe in second stage to open it again.
I
and
think
then
it's
do
a big advantage about the with the free flap that you can start it much earlier. But what is your attitude, for example, for silicone rods in these situations? Do you have experience, and do you put sometimes the silicone rods in very early stage of the treatment, or you're just trying to, you know, put it later because the environment is not so safe for it?
Exactly. So we mainly for sure use it for the flexor side, for the extensor more rarely. And the problem here is you have this contaminated wound, and you know, with silicone inside, we would do this in two stage, and first try to do it with autologous material.
Okay. I think after you can show that, you know, it was many years ago, and I was in a very small department outside of the Poznań, and just fresh after some kind of, I think, internship or somewhere in some other department.
Yeah.
So
Okay.
I did pedicled adipofascial flap from the forearm, because I saw this technique somewhere. And it was really simple for the orthopedic surgeon to do it, you know, just without almost any harm, no donor side mobility, and very easy coverage of this wound. So I did it, and you can show.
So why the Brightman antibiotics? It was the kind of treatment choose to using the pedicle adipofascial flap from the forearm.
Can
Yes.
you show me a picture? Because it was not kind of a perforator flap of the interosseous.
It was randomly based.
Randomly, just
because there is a lot of vessels connecting in some area
now
of the wrist, dorsal wrist and dorsal distal part of the forearm.
And you did reconstruction of the tendon, and you covered it with this fascia flap, and then some skin grafting.
Yeah, like this, but you know, it was not exactly the reconstruction of the tendon. That was probably my mistake, because I put this flap on and I put the skin graft. I wanted to do everything, you know, on one side, on one time, because it was just one shot in this department. I was just helping them in some of the moments, but you know, everything died. Just in a few days, there was a big infection. It looks very nice in the OR, as always. You know, it was very nice. But I think my mistake was not the best debridement, and that's why I showed this case to ask you about your practical tips, because everybody is talking about we have to debride, you have to debride it the best you can. And what are your practical tips for the people that are listening now? How to do a good debridement? And I did a mistake then. You know, I wanted to, you know, leave some tendons. I wanted to leave some maybe tissue, and it was highly contaminated to wound. I didn't know. I don't remember even if I knew about it, because, you know, there was not probably in the report of my younger colleagues then. So how to do debridement like
So for this, I have exactly one sentence for you, and this is: please don't be afraid to create big holes. Because this is the reason why people don't do the correct debridement, because they are afraid of how to do the coverage, and oh, I cannot remove the tendon, oh, I cannot, they are afraid. And this is the situation which we see very often. And if you know there is someone who can reconstruct almost everything, who can do the tendon reconstruction and a big combined flap, whatever it takes, then you are more faithful and more brave to do the debridement. And you really have to remove everything which is looking dirty, smashed, malperfused. Yeah, and the crucial part is don't be afraid of big holes.
How do you do the washout of the wound?
So it depends. We have this this rinsing strategies. We have this how are they called? This pumps.
Like pulse lavage or something?
Yeah,
like
like pulse lavage. Yeah,
replacement.
This is something we do, but finally we do it surgically. We don't, every tissue which looks damaged, we have to debride surgically. This is the main topic.
Okay, so I just, I removed I debrided it, I put the vac for 1 week or two, and then I see the results.
You can consider. Yeah, you see. And also the flap, maybe because I saw that you pedicled it very distally, and know about the anatomy of the perforators. You have to keep this perforator of the distal perforator of the interosseous arteries, which is about 3 centimeters proximal to the distal radioulnar joint of and probably there was too much tension on this perforator, or it was damaged, I don't know. And then
I think it was the first this kind of flap I did, and the next ones are worked really fine, but this one was a combination of problems, because this flap is not so healthy, it's not so strong as a usual flap, and the situation and the local situation was also bad, so we had some problems then. But we debrided, we put the vacuum for 2 weeks. It was not a problem. And then I covered just from the I think a kind of abdominal flap, right? The random based abdominal flap, which is, I think it's coursed by the plastic surgeons and nobody should use it or something like this. But there are some situations like you can use it, or this one, or groin flap. And sometimes if you have a big defect and you need this fat from the flap, works very nice, and it could be done in this situation, in this department, without harm, and it was a good solution for the case, no problem at all. I reconstructed the tendons after a while.
Right. So this could have been a good option for the emergency surgery. Very nice. And then you have the possibility to reopen it and to reconstruct your tendons when you are free of infection, and you have a good interval for that.
Exactly, but it is a kind of case that you can learn a lot about some kind of mistakes and about these initial steps that you told us before. So the management and then the debridement, the preparing, the thinking what will be next, and so that's why these first steps are so important, not to have the problems in the future. Okay, let's go for the second one. I think it will be much shorter and easier, but I see some questions going on. I have also some my questions, but they are questions from the audience. Maybe I can do it in the meantime. What is, from Dr. Bochenek, what is your recommendation for one type of pedicle flap to learn from upper extremity to be as universal as possible? So this is it will be like a miracle, just say us.
Oh, pedicle flap from the upper extremity to do everything in one stage, right? Did I get it right?
Yeah, something like this.
Wow, this is a very hard topic.
Do you know this secret? Do you know this secret that nobody knows? Or
the problem is there are few pedicle flaps at the upper extremity. You have this perforator flaps like interosseous, or the Becker flap from the ulnar perforators, but you have to have some experience, and even with that, they are not very reliable. And for smaller defects, for sure, you have pedicled solutions from like random based flaps, whatever. But for larger defects, it's better to go to a distant flap region, like the groin flap, what you said. Yeah, that's more safe.
Okay, we have next questions. I think so. Also interesting ones. Do you have from Dr. Zeiler? Do you take material for microbiological testing during the first surgery?
Yes, we do. Before we start with the antibiotics, we take soft tissue and bone for microbiology and also for histology. Especially histology when the patient is referred to us after several days after trauma are gone already, to really know about the infection situation of the bone, which is crucial, because we see patients who are coming back 3-4 months after a very nice reconstruction, and then they develop the infect in the bone, and we have to reopen everything. So we want to know the infect strategy.
Do you sometimes culture the bacteria for a longer time, like in the shoulder or hip replacement? We sometimes culture for 2 or 3 weeks for some kind of very mild bacteria, but I don't think it's
in this case.
Yeah. So maybe we can go back for 1 minute for the next case that Arthur was preparing before.
Okay, next case is shorter. It was 50 years old man with left hand injury. It was agriculture accident, crash injury actually. Immediately admitted to the orthopedic department as well. And the injury looked like this.
It's like an avulsion, right?
Yeah, and looked like this. So the skin laceration, extensor tendons was intact. It was flexor broken on the volar side. Index finger vascular supply was completely damaged, and long finger vascular supply was diminished. And the X-ray looked like this. It was multiple fracture in the metacarpal bone phalanx. The head of second metacarpal bone was completely collapsed and broken. On the lateral side looked like this. And the question is what to do with this question, with this case.
The question is, what do the patients want? Yeah, for sure. You can. I think the index finger, it's not to salvage. You have to amputate or do a row amputation, whatever.
I was thinking you will say us that you will fight for it or not. You know,
no. Maybe the third finger, and even with that, you can give it one try. You can do the osteosynthesis. You can try to do the arterial reconstruction, but with this damage, it's like a K4 avulsion injury at the end. You have a very bad or low success rate, and this will keep this patient like 10 days in your hospital. And at the end, you do the amputation of the third row as well. So maybe in this case, it's better to do the amputation at the beginning.
Yeah, so I'm gonna show you what was done.
I think we did the very same solution, because it was very quick to amputate, and everybody would like to be happy and healthy as soon as possible. And if you will talk with the patient in the proper way, it's just better to do it like this, as you said at the beginning. We amputated and we just salvaged and rescued the long one.
Very good.
So bad. It was not so bad. Because sometimes in some of the crushing injuries or some of the other injuries, you see many wounds, you see many problems, but inside it's not so bad. The flexors were okay. There was a lot of crushes and fractures. Yeah, of course.
Yeah.
Okay.
And there is still a K-wire inside. Why he could not do the flexion? Is it
right?
right?
Yeah, just on temporary. Then we did some better stabilization when we knew that the finger just survived and there was no problem with healing. Okay, so
I stopped sharing. Okay.
Okay, so I think we will go back to questions. I have some my own questions and also questions from the floor. Do you use any temporary blood supply devices like drains or shunts to restore blood flow in crushed hand or for the first time of surgery? Some temporary solutions to restore blood flow when you have a gap in the arteria, I think like anterior shunt or some artificial tubes or something like this.
No, usually not. So I think there are very rare indications where this has to be considered. I cannot remember a case where we couldn't do it directly.
Do you think groin flap is the solution of the past?
No.
That you use it, or you can use it, or you cannot use it, or it's a good solution in some of the.
A groin flap is really a good workhorse still nowadays. We use it quite often, even though we are very experienced in micro. This is a very good technique still nowadays.
Okay, I will ask something from my point of view. What would be your attitude for macro replantation, and who should do it? No, if people should do it or not. I mean, amputation on the arm level, because we have replantation centers in Poland, and most of them are taking people with the amputation of the hand, of the fingers. There is no consensus about the macro replantation. From my point of view, it could be done by the vascular surgeon and orthopedic surgeon together in a hospital that can have these two specialties when you don't have any kind of loss of tissues or some other things. What is your opinion about it, Laila? Do you do it in your department? Do you have any results in this kind of amputations?
Yeah, it's the same. I think the crucial point is not the bone. This can be managed, and as proximal you go, it's more easy also for the vascular surgeon to reconstruct the reperfusion. This is what we see very often also in other centers, and after that patients are referred to us. The problems more often are the nerves, because people don't know correctly how to treat them, and this is something we do secondary very often, and then sometimes we are kind of sad that we were not involved earlier, because at the end this is the function of the replanted arm. It's not only to keep the arm without any function, it does not help. So especially this is the point, to have someone who is considering the functional aspects.
I have almost the same opinion, because always we have the same problem, that the vascular supply was done, but the nerves were just left.
Yeah.
And this is the biggest problem, that there is no kind of combined surgery. Even in Germany, this is a problem like this, that the vascular surgeons cannot do it with somebody that knows something more about the nerves, and they are not educated in doing and managing the nerve structures, even if they can manage the vascular structures.
Yeah.
So
that's true problem. Because in Germany the vascular surgeons don't do the nerve, and usually the trauma surgeons don't do the nerve. It's the plastic hand surgeons, and that's difficult, and we see this problem also.
No, then the surgery in this area, when you do the vascular reconstruction and you have the scars and everything, and you have to go secondary, which much worse than do it in primary. So we have the same problems. And also I ask about this question because sometimes these people have to be transported for the replantation center, and they can be revascularized in the local center. But the people think they have to go for the replantation service, but usually they should not go. Sometimes it's even it's even dangerous for them to go anywhere.
The reperfusion time and reperfusion injury after more than 2 or 3 hours, this can be life-threatening, especially in very proximal replantations. So they can do the stabilization, they can do the reperfusion, then they can cover the wound with the VAC, and then refer very safe, very controlled to a center who is doing the rest of the work.
I have a question from Dr. Pavluk, and Dr. Pavluk is supposed to go to your department for the traveling fellowship from FESH this year, but because of the coronavirus, it's not possible.
Really?
He will come.
Oh, that's
he will come.
Sad. I hope you can manage it later. You are more than welcome.
So Marek, now Professor Laila Harhaus, from how she looks like and how friendly she is, so it's not a problem to go there and learn a lot. And he is asking about the case we showed with the crushing injury. Should the second metacarpal bone be resected as well directly by the first operation?
That's a very good question, and we ask ourselves this too every time. Some say they need the bone stock for a stable grip. Some say it's better to narrow the web space. I think it depends, and it's always the right strategy to keep it, and then the patient can try to use his hand, and when he says it's a problem and he cannot use the thumb and he wants you to remove the second, you can do it in a secondary stage.
Right, thank you very much. We have also these problems, which is better, this and that.
Yeah.
Usually we resect a part of this metacarpal, it can be something in between.
Yeah.
So this is a
compromise.
kind of compromise.
You're right.
And you showed the case with the repair and reconstruction of the radial nerve, and then you did the nerve transfers.
Yes.
What was the idea to reconstruct the nerve and then do the transfers?
Yes.
If you know that you will do it.
Yeah, there are exactly 3 reasons why we do the proximal reconstruction anyway. First is to reach the proximal motor targets, for example, the brachioradialis in this case. Second is the sensory, because with the distal nerve transfers, we do not regenerate the sensory. This is coming from proximal. And the third reason is the prevention of neuroma. And these 3 reasons are enough to do the proximal reconstruction whenever possible, and then do the selective nerve transfer for just the distal motor targets.
These are very good general reasons for it, but in case of radial nerve, there are little reasons because the sensory part is not so, I think, important.
Right, but you have the proximal targets and you have the neuroma.
Yeah, you are right.
So,
okay,
yeah.
Thank you very much. That's a very good and nice explanation. I think we have some more questions and they are still coming on. When do you do the groin flap? During the first surgery or later?
Both. It depends on the indication. It really has its standing for different situations. But also in the emergency. Every one of us is able to do this groin flap. This is important for sure. You have to know the anatomy with the circumflex ilium artery, but then it's very reliable and you can solve your problems with that in a good way.
As far as I understand, you work in the workers' compensation hospital. So
Yes.
it's a hospital that is trying to move people more to work, which we have a big problems in many of the countries that people would like to take money and not work. Is that influencing your practice or your decisions? Yes. Or how?
Absolutely. Yeah, it's sad to say, but it influences, because with patients with work-related injuries, we have our task is to do everything possible to get the best possible result for the patient. And this means rehab as much as you need. This means like very expensive neuro MRI examinations, very expensive surgeries, very long ways of reconstruction. We can do everything with them. And when we compare it to a normal patient without workers' compensation, we are very limited, especially in the later phase, especially with the rehab we can offer.
I would ask more about the replantation. It's not maybe very, connected with the subject today, but this is a kind of complex injury too. And what kind of drugs do you use in the, after the surgical replantation of the hand or fingers? Do you have any kind of specific protocol, or do you know any kind of proven things that work? Because that's the point in this kind of questions.
I know there is no consensus. Every center is doing like they want. So what I can do is to tell you what we do.
Yeah.
We do, when we open the anastomosis, we give heparin, which is about 1,000 units. It depends on the height, and aspirin. And then we have a protocol where we do with the fractured heparin, like Clexane, for example, 0.3 twice a day for 5 days, and then reduced once a day for 4 weeks, all in all. And yeah, this is a protocol we use.
Okay, you don't use Dextran or Polfilin or something like this. Okay,
no.
Okay. I remember my boss was all.
Yeah, but we look for the coagulation parts of the lab analysis, and then we optimize for sure the anti-thromby.
Do you use any kind of monitoring of the perfusion or or kind of temperature monitoring?
Yeah, so for the clinical monitoring once every hour, then we do the measurement of the O2 perfusion every finger. Yeah, and we also have this laser imaging, infrared imaging, but in very rare cases, yeah, the clinical assessment is the most important, which everyone can do.
I wanted to comment because my boss was always telling us that he believes in aspirin. I don't know why, but you know, the aspirin is very often said that it should work and it's a good solution. So it's nice to know that you also use it and it's in your practice. One of the last questions, I think, because we almost did everything from the list. What kind of psychological support of these patients that you have with complex injuries? Do you call for the psychologist immediately one day after or 2 days after? Do you have this kind of support there?
We have the lucky situation that we have a department for psychology in our hospital. So they go to the patient as fast as possible, which means they have to be awake and they have to understand the situation, usually after 2 or 3 days. And they lead them through the whole process, the clinical stay and also the rehab stay, and also when they go back to work, they lead them through.
I think everything that is nice has to end sometimes, and I don't see too many more questions. I have something on my list, but they are not so important, I think, to ask and to take your precious time. And I'm really happy that you were with us today and sharing your knowledge and experience. I think it's just too short and too small. We have to do it once again in some of the time on another subject, I think. So thanks a lot. We are really happy, and this is a big thank from our society to you, Laila, for using your time and being with us. Even an hour is a precious hour in our life. We prepared some small diploma for you that I'd like to give to you somehow. I know that the technology is going on and it's really increasing, so we try to do our best, and now I will try to transfer this diploma just directly to you. So this is the diploma. Thank you very much for your help.
Wow, thank you.
Oh, that worked. We
that
didn't
worked.
it before, I didn't know that our society can do like this, but maybe we'll get the Nobel Prize for it.
Yes.
I'm once again, I'm really happy, and I hope you enjoyed the time with us and you shared your opinion and all the expertise.
I have to thank you for your attention and for the opportunity to talk to you, and it was a pleasure, and I would be happy to do it again one day.
Thank you very much. Have a nice day, have a nice evening, take a rest and be happy. Thank you very much.
You too, all of you. Bye-bye.
Thank you very much. Bye-bye.